My objectives are in my title, and that is to demonstrate the realities of sustained nutritional ketosis. But the latter part of the talk is going to be, why is this so hard? And Dr. Palmer just summarized beautifully that a lot of the psychosocial difficulties, I'm not going to focus on those in the latter part. I'll try to talk about some of the physiological difficulties that are readily addressable if we understand them and deal with them properly. So I have two disclosures. I get revenues from a couple books that Jeff and I wrote a decade ago that still sell, which is remarkable. And I am Chief Innovation Officer and founder of Virta Health. I'm going to show you a fair bit of data from our Virta research. Almost all of that has been published in the peer-reviewed literature, and there'll be a couple places where I show you data that's been presented in abstract form, but we've not gotten it through the peer-reviewed process yet. A couple definitions that I think are important. Keto adaptation has been, I think, stolen by some people. And they think that once you have blood ketones above 0.5 or 1 millimolar, you're keto adapted, and that's absolutely not true. Keto adaptation is a very complex process. And depending on which parameter you track in terms of adaptation, whether it's ability to do regular activities of daily living, whether it's ability to do endurance sport, whether it's the adaptation of the kidneys to dealing with the change in organic acid balance in the body, it can take from weeks to months. And it's not something that is just a function of having ketones circulating in the blood. Medical nutrition therapy, and that's what we're now calling the treatment that we've been using and demonstrated effective in the Virta treatment. Most of our patients, I'll show you the data, are able to maintain nutritional ketosis for the better part of a year, but not all of them maintain it for beyond the first year, but they're still restricting carbs. It's very individualized. And so the individualization of personal intake is a very important component of this process. And then the part of Virta that I make no claim to, but which is absolutely critical to the safety and success, is the remote continuous care. I basically got kidnapped by an app developing guru who said, let's put this in a person's pocket in their cell phone, and I said that's not going to work, and I was proven wrong, and I'll show you the data on that as well. I like this picture. This is a photograph taken of two Inuit women and an Inuit male who wasn't looking at the camera, probably around 1910. This is almost assuredly the first camera they'd ever seen. These people had lived on a diet that consisted of meat and fat. People say, they were hunter-gatherers. Well, the gathering opportunities in the Arctic are limited to about 2 months a year. And the berries that you can find, the lingonberries, are so sour that most people refuse to eat them. So these people were essentially pure carnivores. With a great degree of humility, I will say these two women knew more about a well-formulated ketogenic diet and how to do it with the foods available to them than I will ever know. They carried with them 2,000 years of the experience of the modern Inuit in the Arctic. And they had figured out, they weren't scientists, but as Dr. Palmer said, there's an art and a science. They knew more about the art of nutritional ketosis than I will know. Unfortunately, they were not a literate society. They didn't write it down. But there was this cranky guy named Stefansson who trained in what eventually became anthropology, but it was called comparative religions at Harvard. And he got in a fight with his professor at Harvard and left and went into the Arctic for 12 years, from 1905 to 1917. For most of the duration of time, he was out of contact with European settlements for sometimes 2 years at a time. He wore their clothes, he ate their food, he learned their language. And he came back and then wrote about his experience, and said, I could go for 2 years without eating a single piece of vegetable matter, and I didn't get scurvy and I didn't die. Isn't that amazing? And in response to that, he was denigrated, both professionally and in the lay literature, as being a liar, and that it couldn't possibly be true. And in order to salvage his reputation, he allowed himself to be locked up in Bellevue Hospital for 5 months, the first 5 months of a 1-year experiment where he was allowed to eat nothing but meat and fat. And they were sure he was going to get scurvy within, which is easily diagnosable with petechial hemorrhages and loose teeth and joint swelling. They'd usually see it within 3 months. And at the end of 5 months, he didn't have any of those signs. So they let him move into an apartment near Bellevue Hospital and continued out the experiment for a year. And in the end, luckily, the scientists who did this, who were some of the leaders of the early leaders of modern metabolism, published the data in 1930. And luckily, when Stefansson was in this incarcerated situation, and they monitored everything he ate. And so, they weighed the stuff that he ate and wrote it and published it in a paper in 1930. It's actually there are 3 papers together from this experience. And what he ate was 115 grams of protein. He ate over 200 grams of fat per day. So it was a very high fat, moderate protein, and less than 10 grams of carbs. And the carbs only came from the glycogen in the meat that he ate. So this is a pure carnivore diet. And I'm not saying I recommend it, but this clearly is clear evidence that when properly done, a pure carnivore diet can be at least safe in terms of not showing obvious disease in the first year. But notice that, again, he basically ate nose to tail. So brain, marrow, liver, kidney, they didn't, anyway, and it was meat, fish, poultry, anything you could buy in New York City. It was not the Inuits' foods. It was not their native foods. But he was able to more or less recreate that. And so I'm thankful that this got published, because this is what guided me in my research. And the protein represents about 1.5 grams of protein per kilogram reference body weight. And we've subsequently validated, I won't bore you with the old data that I published, but we validated that as adequate in most conditions, other than an infected patient in the hospital, to preserve lean body mass and function in adult patients. The carb restriction will vary depending on the format of the diet one uses, and I'll discuss that later. So this puts this in reference to commonly prescribed or commonly utilized diets. And up at the very top is the ORN, which stands for Dean Ornish's, basically plant-based, vegan, very high carbohydrate, but not high refined carbohydrate, hopefully, diet. And down through the standard American diet, the Mediterranean diet, the paleo diet, which is not a carnivore diet, typically, is typically about 20 to 30% of calories as carbs, 30% of calories as protein, and less than 50% or less calories as fat. This is not a keto diet. It's low carb, but it's not keto. In order to be in nutritional ketosis, you're stuck in that little blue island at the bottom in the middle there, which is typically less than 10% of calories as carbs, down to approaching zero, although with real foods you can't eat a zero carb diet, because even glycogen, eggs have some carbs in them. Meat and eggs have glycogen and other carbs in them. That it's not high protein. If you go to very high protein, you can't eat any carbs, because the protein itself stimulates insulin, and so the higher protein intake does, to some degree, suppress insulin or suppress ketones because of the insulin stimulatory effect of the protein. So this puts this in perspective, that in order to be on a ketogenic diet, you are in a very narrow range of nutrient intakes. So it's not an easy diet to follow just in terms of guiding patients to their appropriate personal level of protein and keeping carbs in a range where they're satisfied with food choices, but not given enough carbs that it suppresses nutritional ketosis. Because if you don't have ketones, it's not a ketogenic diet, and you will not keto adapt. So I don't like the concept of macros because, and I'll go into that later in the talk, but this is the kind of the outline of fat, protein, and carbohydrates that one would consume as part of a well-formulated ketogenic diet when one is at weight maintenance. And this is a really important point. If you start a ketogenic diet and you're losing weight, the macros of what you take in aren't the macros of what your body's burning if you're burning fat, because you have to add that fat to the metabolic energy expenditure. So and I'll have a further slide on this, but people say, well, what macro should I follow in a ketogenic diet? And I say it depends. It depends on what your goals are, what your metabolic tolerances are of carbohydrate, and what stage you are in the process if you're in the process of losing weight. Where we stand pretty strongly and really haven't changed our views in the last 25 or 30 years is the evidence is that nutritional ketosis begins at 0.5 millimolar beta-hydroxybutyrate, extends up to about 3 millimolar. If you exercise, there's something called post-exercise ketosis, or the Cortes-Douglas effect, that was at first published by Tim Noakes, actually, before he became a proponent of carb restriction. And that can take people up to about 4 millimolar. 4 to 7 millimolar is starvation ketosis, but ketoacidosis doesn't start till you get above 10 millimolar beta-hydroxybutyrate. We get worried in people with type 1 diabetes or burned out stage type 2 diabetes if their ketones are getting up in the higher range. So we worry that maybe they're going towards it, but you don't get into acidemia until you get above 10 millimolar. So when you talk about the fed state with 0.1 to 0.2, compare that to 1 to 2 for nutritional ketosis, and ketoacidosis starting at 10, there's a 10-fold difference between the two. These are distinct metabolic states. They're not blurred. And with the advent of the fingerstick ketone measurement, which is dramatically more effective and accurate than urinary ketones, we have the ability to track this, and patients get direct feedback by doing self-testing. Now, it was in the revolution that I was part of 40 years ago was saying, look, in starvation, your brain lives on ketones because you're not eating any carbohydrate. But with a ketogenic diet, your brain can live on ketones because you're making them and you're not eating carbs. So nutritional ketosis feeds the brain, and that allows the person to feel well and function well in the absence of significant dietary carbohydrate intake. And we thought that was, and that was a hard thing to sell. But recently, there's really a revolution in ketones since 2013, and that is that we now understand that they're metabolically signaling molecules, and that they actually affect our metabolism through epigenetic regulation. And part of that process is that signaling is it reduces oxidative stress and inflammation. The key papers in that were published by the group at the Buck Institute with Eric Verdin and David, anyway. So basically what they demonstrated is that in an animal model, they could infuse ketones, and literally in a matter of a few hours, they could affect histone deacetylases, which regulate key genes in our defense against oxidative stress and inflammation. So when you have, and this is a very early stage of keto adaptation, but it's a prompt response the body has that you act when you cut out carbs and you have ketones come up above 0.5 millimolar in the blood. It turns on genes. It allows genes to function that you've had since birth, but probably got turned off when you got weaned onto carbohydrate-containing foods. And then the subsequent paper that John Newman and Eric Verdin published, it was on ketones as another effect of signaling other epigenetic effects that improve insulin action and reduce insulin resistance. So we actually have mechanisms for how this might have a direct and beneficial effect on type 2 diabetes. But the other change that has been really important is we now understand, based on work that came from Yale University, from Dr. Dixit's group, that beta-hydroxybutyrate has a direct effect on the assembly of a genetic regulatory entity called the NLRP3 inflammasome. And this is like a regulating gene expression control that alters multiple downstream genes in the inflammatory cascade. And so this explains the dramatic anti-inflammatory effects that we see once people are effectively keto adapted. It doesn't happen immediately, but it's a very potent and lasting effect, and I'll show you data on that. In addition, because the beta-hydroxybutyrate alters the epigenetic effect on histone deacetylases and reduces oxidative stress, that is, reactive oxygen species. And this gets in deep into biochemistry, and I just want to flash this up to say that when you have beta-hydroxybutyrate present, it reduces the impact of reactive oxygen species on membrane polyunsaturated fatty acids, which get turned into pro-inflammatory agents called isoprostanes. And they've been known, the isoprostanes were discovered about 30 years ago. They're very difficult to study because they were not controlled by genes or by protein enzymes. They're just, our reactive oxygen species just attack a membrane. There's no enzyme involved. And when it attacks the membranes and damages the polyunsaturated lipid, it produces pro-inflammatory compounds. And that we're exploring the fact that that has very significant effect on membranes, and that those pro-inflammatory components of membrane degradation can have multiple effects throughout the body. And if you degrade polyunsaturated membranes, fats in membranes in muscle, you increase muscle insulin resistance. That's a long story, and I want to skate by that without getting into too much detail, but it's again, gives us a very credible mechanism for why we see dramatic effects on type 2 diabetes when we counsel patients and get them to follow a well-formulated ketogenic diet. So this concept of inflammation as having a role in diabetes is a new concept, but we're making progress. The first paper that I can identify that was in a mainstream journal that said, look, this is important, was the first of these papers by Donath and Donath and Schnolson that was published in 2011. And this is a Swiss group, and this was looked upon with great askance. But those guys are pioneers, okay? The second paper, which came from here in San Diego, from UCSD, by Jerry Olewski's group. These are leaders, these are thought leaders in diabetology. And when they publish a paper in Journal of Clinical Investigation, it says inflammatory mechanisms linking obesity and metabolic disease, these guys are settlers. When the mainstream says, this could be important, and they put it in a top-ranked medical journal, then you know we're making progress. So, and this is a pattern we see. We see pioneers and we see settlers. And I'm delighted the fact that I'm probably a pioneer, but there's some really great people who are settlers in this room and others who've come in, and they're doing what I could never do, because that's just not in my character to build fences and raise cattle, in fact, fenced in a ranch or something. Anyway, getting to data. Probably one of the most important papers I was involved with was a study that was done primarily by Jeff Volek's group, and we published this back in 2008. And this was a randomized controlled trial of people with metabolic syndrome, not really severe metabolic syndrome. And actually, it turned out it was done at the University of Connecticut, and most of these patients were members of the campus police force, which is good because they knew how to follow orders. And the woman, the first, Cassandra Forsyth, who was the lead author on the paper, was a female bodybuilder, and she could give orders to cops. And what they did was they randomized them to 2 dietary interventions. One dietary intervention was a well-formulated ketogenic diet. And they were told to eat this diet, which is shown here on the right-hand side, LCD, which was about 20+% protein, and I can't really read the numbers there without my glasses, but it was about 12% carbs. And you say, well, that's a lot of carbs, except that they were told to eat this to satiety. And we knew from previous utilization of this diet, Jeff had published multiple studies with a well-formulated ketogenic diet in overweight people, and they typically undereat by 1,000 calories a day. So he knew that they'd be eating about 1,500 calories a day. So the other arm got randomized to a quote, balanced diet, a low-fat diet, where they were told to only eat 1,500 calories per day. So one was a restricted diet, one was eaten to satiety. I'll note at the bottom that on the low-fat diet, they only ate 12 grams of saturated fat per day. On the high-fat diet, they were eating 36 grams of saturated fat per day. They were eating a lot more fat than that. This wasn't high saturated fat in proportion, but they were eating 3 times as much saturated fat on the low carbohydrate diet arm. As we usually see, when you do a well-formulated ketogenic diet right, including paying attention to minerals and electrolytes, and I'll come to that later in the talk, the people on the ketogenic diet lost twice as much weight as the people on the low-fat, high-carb diet. People say, well, yeah, but they lose more fat or more weight because they lose a lot of body water from the natriuretic or diuretic effect of the ketogenic diet. And they did accurate DEXA measurements on these people, and only 1 kilogram of that 5 kilogram difference came from body water. The rest came from body fat. So that there was greater mobilization of body fat, and people misinterpret this and say, okay, so that means that you have this metabolic advantage of a ketogenic diet. You lose more body fat because you're burning more calories. So they're both eating 1,500 calories, right? Well, this is an outpatient study that lasted 3 months. And you don't get perfect adherence from any human being in an outpatient study. You have to understand that. And for people who are told to restrict their calories and they're not getting the appetite suppressive effect of ketones, that weight loss in the low-fat, high-carb group is actually very good. But they probably weren't as adherent as the people on the ketogenic diet to following dietary recommendations. But the most fascinating data is not the weight change, but it's the change in metabolic and risk parameters. And so on this complex graph, if you look at those factors which are outlined in green, those 4 factors outlined in green are the parameters that define metabolic syndrome. And you can see that abdominal fat, which is, we didn't do waist circumference, but abdominal fat content by DEXA was significantly, the loss was significantly greater with the ketogenic diet in red. Triglyceride reductions were dramatically better. Both the other groups were restricting calories, losing weight, so they were getting better. That diet is working to improve their metabolic health, but the ketogenic diet worked better. In terms of HDL cholesterol, there was about a 15% rise in HDL cholesterol with the ketogenic diet. There was no change with the other diet. And we see this over and over again, that we get a significant increase in HDL concurrent with the reduction in triglycerides, and you've heard in previous talks, that's a very powerful predictor of reduced atherogenic risk. And then blood glucose, which wasn't super high in these patients anyway, went down somewhat. That's the screen bar here. So the blood glucose reduction and increase in HDL. The other really important factors, insulin resistance measured by HOMA-IR, we saw a dramatic reduction in insulin resistance in this group. Reductions in both, but a dramatic difference. But the most paradoxical finding is on the far right, outlined in orange, and that's the blood level of saturated fat. Now, we've heard that dietary saturated fat, the evidence now is, and mainstream thinking is, it's not harmful if you eat saturated fat in your diet. But there is strong evidence that says the amount of saturated fat in your blood is a predictor of future diabetes risk, coronary artery disease risk, and mortality. So here's the paradox. The group with the red bar, those on the ketogenic diet, had much greater reduction in saturated fat in their blood, but they were eating 3 times as many grams of saturated fat per day. So if you were taught, and if you still believe that you are what you eat, red X. This is not true. You are what you save from what you eat. And the answer to this probably is that when people we get keto adapted, we more than double our body's ability to burn fat. And one of the preferred fats used in that fat oxidation is saturated fat. So it isn't going to harm you if you take it in, you turn it into CO2 and water. You may raise atmospheric CO2 and might add to global warming, but it's tremendous benefit to your health if you reduce blood levels of saturated fat. And we've now seen that in 5 separate studies. This is not an isolated observation. And finally, in this study, Cassandra Forsyth, working in a lab carefully with, diligently measured 14 biomarkers that are associated with inflammation. And of those 14 biomarkers, 7 of them went down significantly more in the group on the high-fat, low-carb diet than in the control diet. None of them went down more in the group that was on the low-fat, high-carb diet. So a clear beneficial effect on shown in the ketogenic diet relative to the high-carb, low-fat diet. The interesting thing is I mark in over here on the side here is that C-reactive protein here was one of the 7 that did not go down on the ketogenic diet in the first 3 months. It doesn't mean it doesn't go down. It means it doesn't go down in the first 3 months. It's a slow responder. So when you read papers, including one by Kevin Hall, just recently published, that says that the ketogenic diet followed for a month makes CRP go up, he's so impatient. Hang with it, dude. I wish I could say it to him directly. Anyway. So these are, because he's just an irrational critic. He wants to find fault with this, and he'll publish short-term data and get the opposite result, and then say, see, we proved that the ketogenic diet is pro-inflammatory. More to come, because I'm going to show you some as yet unpublished data, well, published and unpublished data that corroborates what I'm just harping on. So let's talk about what this does in diabetes. Dr. Westman pointed out in his talk that the low-carb diet was the only treatment for diabetes prior to the advent of insulin and modern pharmacology. So that's not new. But with the advent of insulin and other drugs coming along, the ketogenic diet really fell out of favor by about World War II or shortly after in terms of managing type 2 diabetes. And there was a drought in information on this, and really no modern studies that looked at this until in 1976, a gentleman named Bruce Bistrian, MD, PhD, MPH, former Navy SEAL, and published this paper in the journal Diabetes, a prominent journal, saying that you can reverse type 2 diabetes with a ketogenic diet. He did not use a low-carb, high-fat diet. He used a very low-calorie ketogenic diet, basically lean meat, fish, poultry, and calories in the range of 400 to 800 calories per day. And he recruited 7 people with type 2 diabetes, all of them taking insulin. And in order to manage them safely, 6 of the 7 were admitted to a metabolic research ward and followed for months, a month or many months, during which time they managed their diabetes and withdrew their meds, as was the common practice in the day. Rather than having a table of here are the 7 patients, he showed all the data, 1 patient at a time. So what you see here at the top is the blood glucose values and their weight. This thing in the middle here is he's actually looking at how their body uses protein. We're not going to get into those details, But suffice it to say that he was actually studying how much protein a person needed when you severely restricted their calories and got them into nutritional ketosis to prevent the lean body mass loss that is always seen with total fasting. And it's kind of hidden down here, but this is the insulin dosage over time that the patient got. And this patient who started out on 52 units of insulin a day had her insulin completely withdrawn at day 19. And that was the longest period of time that a patient who went on this regimen in the metabolic ward took to withdraw their insulin. Some of the people, he withdrew their insulin in 2 or 3 days. And the reason they were in a metabolic ward was this is the only safe way to do that when you have somebody on a dangerous drug like insulin and you radically change their ability to manage glucose. And if you leave them on the insulin, as you all know, they're going to become hypoglycemic, and you can have major adverse events or fatalities from doing that. So this was only safely done in the metabolic ward. But you'll note that there's one patient, it was 6 out of 7, the one patient who wasn't in the metabolic ward was one of their employees, and they worked with the guy every day. And so they let him do it as an outpatient. And they just sort of said, well, we just let him do that. So this was really a pioneering paper, published in 1976. I read this paper when it came out, and I was finishing my internal medicine residency in Vermont, and I said, I got to go meet this guy. And I went down to meet him, and I stayed 3.5 years. And that's how I got roped into this whole thing. So this was a pioneering change. After this, up until Eric Westman and Will Yancey started publishing their data in the early 2000s on the effect of a ketogenic diet on people with type 2 diabetes, there was a total drought. This guy, it's like he's a Navy SEAL, because he was a leader and he was willing to take the point and stand out there and defend his data. Finally, in 2005, Gunter Boden at Temple University did what I think is an absolutely brilliant and beautiful study that corroborates, and this is the first settlement study, if you will, that I can identify along with Eric and Will's papers that they published. And what he did was he recruited 10 people with diabetes on medication, and he brought them into a metabolic ward where he could do this safely. And for a week, he had them eat from a buffet, choose as much food as they wanted to eat from a buffet of very nice, good foods that were rich in carbohydrates and relatively low in fat. And they monitored what they ate, and they ate about 3,100 calories per day. Now, these are severely overweight individuals, and they held their weight stable, and they measured their blood glucose, which is shown in the top panel here in the black, and their blood insulin levels, shown here. So high glucose, and this is millimolar glucose. Normal glucose is 5.5, the upper limit of normal is 5.5. So this is where normal is, and these people were running glucoses across the day around or above 200 milligrams per deciliter, so about twice normal. And then they took away all the carbs from the food, but still had very good, delicious foods out there, and they could eat from the buffet and had them eat as much as they wanted to, and they spontaneously reduced their calorie intake by 1,000 calories a day, which is exactly what Jeff had seen when we predicted in that 2008 study that we published. So they reduced their calorie intake by 1,000 calories a day, and yet they reported better satiety. And in 2 weeks, when they went back and did their blood glucoses, and these are blood glucoses done every 2 hours across 24 hours, and looked at their insulin levels, they had a dramatic reduction. And remember, 5.5 is the upper limit of normal. So upper limit of normal is here. These are their glucoses after just 2 weeks of the ketogenic diet. And you can see that they're in range, in the normal range, most of the day after just 2 weeks. And they'd only lost 2 kilograms of weight loss, only 2 kilograms of weight. This is not a rapid weight loss diet. It's not designed to be weight loss. It's to be a metabolic improvement diet, if you will. And yet they had markedly reduced blood glucoses, but at a markedly lower insulin level, if you'll see in the lower panel in blue. Now, the only way you can reduce your blood glucose and have with lower insulins is you have to improve your insulin sensitivity. But Gunther Boden was trained with Cahill and at the Joslin back in the heyday of starvation studies, and they knew how to do euglycemic clamps, which is the definitive way to test insulin sensitivity. And what they demonstrated was there was a 75% reduction in insulin resistance, or a 75% improvement in insulin sensitivity in 2 weeks with very little weight loss, which means this is not what many of the critics say, well, any diet works if you lose weight. You don't need to lose weight on this diet to get most of the benefits. And again, this is very early in the adaptation process, and things get better with time. So this was, again, a metabolic ward study. They took away more than half of their medicines in the first 2 weeks. When you initiate this diet in somebody with diabetes or severe hypertension, it's metabolic rock and roll. Things change quickly. And it's not safe to do this as an outpatient unless in that one salient case of Bistrians, it was an employee that they worked with every day. Unless or until some guy from Silicon Valley comes along and says, let's make an app and put it in people's pockets, and we'll interact with them every day. So this is how Virta got started. And the key technology here is you can do this safely in outpatients if you have constant communication and expert physicians and coaches managing that patient. The low-carb message is important. So you can see me down here in the corner. My only role here is what we'd already done, which is the carb-restricted diet and the details of how to do it safely and effectively. You can see the same blue shirt that I'm wearing now. But basically, this is a patient-centric program and a patient-centric app. This is not an app that's designed for billing, and we need to start learning how to do that, but it's really designed with having the coach in the upper right-hand corner and the doctor in the lower right-hand corner interacting with the patients, the patient monitoring data and logging it in through the app and getting access to their data through the app so they see all their data. And the other thing is putting the patient in contact with a peer support group, which augments the coaching process to allow them the comfort and security to know that they're doing the right thing and that other people are dealing with the same problems and communicate among themselves in terms of peer teaching. So this study got underway when one day in Denver 6.5 years ago, Dr. Sarah Hallberg walked up to me. I'd never met her. I didn't know who she was. And she was very subtle in her approach. She said, "Steve Phinney, we got to talk." She said, "I read your books. I'm using it in my practice, and I'm getting amazing results with diabetes and obesity. But do you know that some of those patients have dramatic elevations in their LDL?" She says, "It's scaring the heck out of my referring physicians." She said, "What are you going to do about that?" I said, name tag, "Dr. Hallberg, would you like to do a study?" And that's how we got into this thing where we recruited 262 people with type 2 diabetes in the Lafayette, Indiana area. We also recruited about 130 patients with pre-diabetes, but I'll focus on the diabetes patients. And we recruited almost 100 patients from the adjacent diabetes management program clinic, the standard of care clinic run by diabetologists and certified diabetes educator dietitians, et cetera. And these were people with type 2 diabetes. The average duration of their diabetes, which is important, was 8.4 years. It's much easier to reverse or treat or improve diabetes in people early on in their diagnosis. But when they've been at this for an average of 8 years, there's a lot that's been going on in the pancreas. These are tough patients to deal with. They were very obese. They had a BMI of 41. And the diet that we used with these patients was basically what we did with the metabolic syndrome study that I showed you that Jeff Volek and his team did. And it was basically 1.5 grams of protein per kilogram reference body weight, again, based on the observations of Stefansson when he was locked up in Bellevue Hospital. Because they were very insulin resistant and type 2 diabetes, we gave them only 30 grams of total carbs per day. And here's the important thing. We had them eat fat to satiety. This is not a calorie-restricted program. We did not count calories. We did not tell them to restrict calories. We told them not to be hungry. Eat to satiety. And we started out, and the other thing I'll tell you is half of these people were treated through the app, which we were just in the process of developing. And we didn't know the app would be an effective way to do it. So the other half were treated in in-person groups that met 25 times in the first year. So we had in-person group training and management and in-person physician monitoring and so on, and the other half got this incipient app that we were developing, and I was sure the app wasn't going to work. Because I know that interacting with patients, I mean, Dr. Hallberg is a force of nature. You talk to her, she'll get you to do amazing things. We didn't see any difference in the first year between the two. Prove myself wrong. I like doing that because that's how I learn. We've published, these are 6 papers that we had published as of 2 years ago. We have another 3 papers published and another 10 or 15 abstracts and papers in process. This has been an extremely productive study and very rewarding as a biomedical scientist. If you read any one paper, read our 2-year data from Frontiers of Endocrinology, which shows that the 2-year data from our randomized clinical trial. I'll show you some of these data here. This answers the first question. Can people really stick with this kind of program? We had 83% retention at 1 year and 74% retention at 2 years in the intervention program. We had similar retention in the usual care, but they weren't being told to make radical changes in their diet. So excellent retention. And in the lower right-hand side of this diagram, you can see blood ketones that were being measured every day, reported through the app. And you can see that, again, this is a very insulin-resistant population, and yet the group mean ketone increase was up to 0.8, and they maintained that for the first 3 or 4 months, and they stayed at or above 0.5 out to 8 months. And even at the end of a year, they were about 0.4. So people can follow this diet. They can stay in nutritional ketosis if you give them the right information and adequate support to help them do that. It's tremendous benefit to adherence when people come off of their drugs and their weight goes down and they're looking at blood sugars that are better than anything they've seen in 8 years. That's remarkable. What happened to hemoglobin A1C? The blue bar at the bottom is our intervention, the 2 intervention groups together. The black line at top is the group of patients who were in the usual care. And it's a standard understanding that type 2 diabetes is a chronic progressive disease, and these people, hemoglobin A1C was slowly going up even in the course of 2 years. And it depends on whether you talk about remission. We like to talk about reversal, because remission sounds like you got to a destination, and I like the term reversal because it means you're going back in the right direction towards metabolic health. Reversal means we take them off all their diabetic medicines except metformin. And we had 55% of people at the end of 1 year who had reversed their diabetes by those criteria. This shows medication use. It's kind of complex, but on the far left-hand side is our sulfonylureas and insulin. The sulfonylureas we completely withdrew because they're very dangerous drugs in terms of inducing hypoglycemia. 54% of the patients stopped their insulin, and another almost 40% reduced their insulin, and only 8% of the patients didn't reduce their insulin in the course of the study. The drugs in the middle were drugs that we didn't regard as dangerous and weren't as active in reducing them. And on the far right-hand side, you see metformin. If the people were on metformin and had no side effects from it, we did not stop it. In some studies of diabetes reversal with very low-calorie, low-carb diets, they just automatically stop all meds, including metformin. But I think there are ethical issues of stopping a drug that isn't having side effects, that's very cheap, and which has known benefits of preventing progression to diabetes. Because this cohort of people are at very high risk of progressing to type 2 diabetes. So we don't stop it. But that's a discussion issue. It's not standard of care. This is a Eat to Satiety study. It was not a calorie-restricted diet. We weren't focusing on weight loss. But this shows you the weight change for the two cohorts across 2 years. And you can guess that the blue patients are the ones who were on the Virta program. And we had progressive weight loss down to 1 year. We did not see, as a cohort, the group begin to start regaining some weight till about 14 months into the treatment. And there was about a 5-pound weight regain between 1 year and 2 years. So there is some weight regain that we saw in the second year, but it was very modest compared to what one sees in a lifestyle program. And I'll show you from data from other studies in a couple minutes. You've already seen these data, and so I thank the prior speakers for projecting them, but we saw a 12% reduction in 10-year atherosclerosis risk based on a standard predictive equation. The one thing that, the blue bars are, anything going up is improvement, reduced risk, anything going down is increased risk. The only blue bar going down, which is our intervention group, was LDL cholesterol. But if you look over here on this side, this is the small, dense LDL, the atherogenic LDL. So it improved, even though LDL slightly increased. The other thing I'll point out is, with the purple bar over there, that's C-reactive protein. Remember, at 3 months, it doesn't go down. And in this study, I won't show you, CRP did not go down in the first 70 days of the study. But at 1 year, we saw a dramatic improvement in CRP, and also an improvement in white blood cell count right next to it, which are both recognized predictors of diabetes risk and heart attack risk. And then I'm going to break protocol and show you data that we haven't published yet in the peer-reviewed literature. We presented this to the Endocrine Society meeting last year, but these are 16 biomarkers of inflammation that we measured at 1 year and 2 years in this population. Remember, in the 3-month time frame, only 7 of the 14 went down significantly with the ketogenic diet. Here we've got 14 out of 16 going down. And if you're into statistics and you want to say, well, how powerful is that? All 14 of those 16 that we say went down significantly, the p-value was 0.001 or less. And so what we're looking at here is a broad spectrum anti-inflammatory intervention. If you take an anti-inflammatory drug like the modern statins reduce CRP. They'll reduce it about 25%. In patients who adhere to the drug for a year or longer, but it has no effect on other biomarkers of inflammation. It's a single-focused drug. This is a much broader perspective, effective drug. So just wrapping up, when I used to think that the value of ketones was it takes fat and process it in the liver and you make fuel for the brain. That was the 1960s thinking. And then what we now know is it's an excellent fuel for the heart, and also, very interestingly, beta-hydroxybutyrate is an extremely effective fuel for the gut. Now, beta-hydroxybutyrate is a 4-carbon fatty acid with 1 extra oxygen added to it, beta-hydroxybutyrate. If you are an aficionado of the microbiome and fiber for gut health, a good microbiome, given a good source of fiber, makes something called butyrate. 4 carbons, no 1 double bond, no extra oxygen. They differ by 1 molecule. Both of them are superb fuels for gut mucosa. They both have anti-inflammatory effects in the gut, although the anti-inflammatory effects of beta-hydroxybutyrate are probably better. So if you're worried about gut health on a pure carnivore diet, if you got ketones of 1.0, don't worry. My liver makes probably 100 grams of beta-hydroxybutyrate a day. I'm guessing, but based on good science from other people, or maybe healthier than I am. The gut probably needs 5 to 10 grams of either butyrate or beta-hydroxybutyrate a day. So I got plenty left over for my brain. But anyway. Now let me try to be a little bit provocative and throw some stones at other studies. So this looks at the problem of weight rebound in multiple studies. Some of them were very calorie-restricted diets. So the green line here that goes up to there, that's called the DIRECT study that was published in The Lancet a couple of years ago. And this is a formula, roughly 850 calorie formula diet to treat people with early stage diabetes. What they do is they have the people follow this, take this liquid formula providing only 850 calories a day for 3 to 5 months, and then they have them go back on a healthy diet. So this drop here is 3 to 5 months of drinking a liquid formula, and then when they go back on a healthy diet, their weight starts going up. The purple here is a very low calorie. This study was actually published in the 1990s, but they used Optifast at 500 calories a day for 3 months. Then they took them off the Optifast and told them to eat a low-calorie diet for a few months. Then they put them back on Optifast, but you can see great response initially, but the second time they had them drink this 500-calorie-a-day formula, it didn't work. And it probably didn't work because once they've been on it and went off it, when they go back on it, the body is, the signals to the brain are so intense to eat that they couldn't adhere. But anyway, they did this and I really credit this team in Pittsburgh, Dr. Rena Wing and her team, because they published these data, because they showed that this is weight went down, but when they went back on the low-calorie diet after the second try of the very low-calorie diet, by the end of a year they're going back up, and much of their weight was regained. So by 2 years. So this is a dramatic change in their weight, both down and back up. And this is a classic response. Remember Oprah Winfrey, but most of you are too young to remember that Oprah Winfrey went on Optifast for 5 months and lost 67 pounds. And walked out on stage with this baggy clothing and said, "Ta-da, let's see my size 10 jeans." And it was dramatic. It was wonderful. But then she gained it all back in the next 7 months because there was no follow-on. And that's what has been seen over and over and over with extreme calorie restriction and no attention to a long-term management plan. And then the blue here in the middle is Virta. And we go down, we stay down at 1 year, and then there, as I showed you, a slight weight regain. This shows hemoglobin A1C changes. Again, you get a much bigger drop when you're on an extreme diet, but then it goes right back up when you no longer follow the diet. If you have something that can be sustained long-term, you have a much greater likelihood of achieving lasting benefit. Stay with me. I'm hopefully getting not too far from the end here. Okay. These studies include patients with diabetes with gastric bypass or gastric sleeve surgery, plus the Look Ahead study, which was a very intensive lifestyle intervention. And you can see that it's a common observation that everything goes down when you have a very effective treatment, but for most of them, it's going back up. Oh, by the way, this one that's completely flat here, this was the control group for the Look Ahead study where they did no intervention. And no change in their diabetes, and luckily no upward trend. But again, you get a lower slope and better lasting results when you deal with something which is sustainable and planned to be followed long term, and that's what we do with the well-formulated ketogenic diet. And now I kind of want to pick a fight with my personal friend and colleague, Christopher Gardner at Stanford, because he published a study, a very provocative study in 2007 called the A to Z study, and A stood for Atkins and Z stood for the zone diet. They studied four different diets, but I want to highlight in the solid green at the top, these two bars. This was a group of patients with obesity, not diabetes, who went through a 3-month training program with something called the LEARN program that was developed by Dr. Kelly Brownell, who was an excellent behavioral medicine scientist at that time at Yale. And they lost weight, and they kept much of it off over the course of a year, but it was about 3 to 4% of body weight. When they did the Atkins diet, they lost more, and they kept more of it off, but out here it wasn't statistically different, significantly different, so I said, see, there's no difference between these two diets. But the effects were very modest, and weight regain began at 6 months after the Atkins diet. The orange bars, solid and dotted here, this is a study called the Diet Fit Study they published in 2018, where they recruited overweight women not with diabetes, and half of them were given a healthy low-fat diet, and half of them were given a, quote, ketogenic diet. And so the healthy low-fat diet is in the orange right here. And see, they did better than the behavioral group here, but they started gaining at the end of the first year. This was the healthy ketogenic diet that they used, but I need to put ketogenic in air quotes because they started out at 20 grams of carbs per day. They got 22 meetings with the research dietitian over the course of a year. But by the end of the first month, they were told, we know that it's really hard to follow a 20 gram carbohydrate intake diet. So you can add back carbs till you get to a point where you're eating enough carbs that you think you can follow this for a year. And what they got was the same kind of downward curve starting back up. And when they got out here, they were eating something on the order of, I think it was 39% of their calories as carbs. And this group was eating 52% of the calories as carbs. So they differed significantly amount of carbs, but the outcomes weren't different. So the conclusion in JAMA was both diets work, but there's no difference between the two of them. But it wasn't a ketogenic diet. But so we'd get, you can design studies that get the result you want. But you can't say it was a ketogenic diet. So the question is, why is lasting success with ketogenic diets so hard? And part of that I've already answered. I said, if carbs and protein are greater than 30% per day of your daily, not your daily intake, but your daily energy expenditure, because remember, you have to add this metabolic contribution if you're losing weight. If you're above that, you're going to be marginally in ketosis, or if you're insulin resistant, not in ketosis. So if it's not a ketogenic diet, you're not going to get the benefits of nutritional ketosis. And the second point is, there's lots more than simply carb restriction. I don't want to belabor this too much, but as I pointed out, your macros are different depending on where you are in your path of keto adaptation. And as somebody starts out with weight to lose and they start on the ketogenic diet, they are going to be losing weight. And so to get the right amount of protein, it has to be a higher proportion of your calories. But as you go through this odyssey and you lose weight, as you lose weight to some degree, unless you do a lot more exercise, your metabolic rate is going to come down somewhat, so your needs are different. But by the time you get out to weight maintenance, the macros are different. And the way that you meet the person where they need to be in terms of energy intake is to add fat. And it takes a lot of education to get them to add fat to that process, to achieve weight stability and maintain nutritional ketosis. I'm known to harp on minerals and vitamins. I just want to show you 2 or 3 slides because the biggest problems that we deal with that are easily manageable is getting people to eat enough sodium and eat enough potassium. Because if you don't, there's problems. So for sodium, if you don't eat enough sodium when you're on a ketogenic diet, because you have this natriuresis of fasting, the kidneys accelerating their loss of sodium, you will become sodium depleted, and that will lead to renin, angiotensin, and aldosterone process moderated by the kidneys, which leads to increased cortisol and cortisol stress. And people say, oh, well, that's the Atkins flu if you have headache and fatigue and dizziness. And if it goes on a long time and you just feel crappy all the time, they'll say, well, you've got adrenal fatigue. There is no medical diagnosis of adrenal fatigue. That's sodium inadequacy. It's not adrenal fatigue. And you don't wait till it happens and say, oh, I'll give them a gram of sodium or 2 grams today. You treat them with the sodium from day one. When we send a starter kit to the patient, we send it with their choice of vegetarian or chicken bouillon, actually one of each, because they taste it and find out what they want to buy. We have to give them the stuff to start with to get them to take it and understand that it's necessary. Is that safe? Well, there's an amazing study published in the New England Journal of Medicine 2014 by a group at McMaster University in Ontario, Canada. But the study was from 102,000 people from 17 countries where they did something really innovative in terms of studying sodium requirements. They didn't say, ask them in Urdu or in Dutch or whichever language, how much sodium did you eat yesterday? They said, pee in this cup. And a morning void sodium is 85% accurate in terms of how much sodium, it tells you how much sodium you ate yesterday. If you're talking about 2 or 3 people, that 15% inaccuracy is statistically messy. If you're dealing with 102,000 people, it's a rounding error. What this shows is the mortality curve for the measured sodium excretion as a surrogate for sodium intake, and this is the 2.3 grams that we're all told we should be eating. And you can see that the mortality risk here is 1.5 times the lowest point, which is at between 4 and 5 grams of sodium per day. So for healthy populations, this is not a disease population, but ambulatory general population, the healthiest sodium intake across 7 different countries is between 4 and 5 grams of sodium per day. And if you eat more than that, you can see the curve as it goes out to the right doesn't go up very fast, but it goes up really fast if you severely restrict sodium. So sodium's absolutely necessary. We see the same kind of things with potassium. And I titled this slide, The Role of Vegetables in Broth. And the reason is that if you're a pure carnivore and you eat 1.5 grams of protein per kilo, which is about 15% of energy intake, you're going to be at about 1 gram of potassium intake per day. If you eat 3 grams per kilo or 30%, you'll be over here. So this idea that you have to eat 30% of your protein will actually give you enough potassium to be reasonably safe. But if you're eating 1.5 grams per kilo, you have to get your potassium from somewhere else. And if you add 3 or 5 servings of vegetables per day, and if you then add homemade broth to this, you can get out to a place where it's very safe. But if you restrict protein to the amount needed to maintain lean body mass, then you have to have another source of potassium. And that's where, in many cultures, gathered foods came in. So, just a point of safety. Saturated fats you already heard about, and I showed you our data. So with that, I'll end, and thank you very much.
Interesting history note. The Optifast program, if I would have known you then, that was in the mid-'80s, I believe. Anyway, Sandoz was the company that made Optifast, right? They called me to test because they were getting that kind of bump back up when the people, but they were still getting counseling in Optifast. This was the protein-sparing modified fast supplement, basically.
Yeah.
Anyway, so they came to me, and I worked with Richard Hoffman in Staten Island, who was the endocrinologist in charge of that. And I did a study where we gave half of the people that were still getting the same counseling, the same food, just put them on a simple exercise program, okay? And after 12 weeks, their resting metabolic rate kept going up a little bit, and the ones that didn't exercise did the same intervention, resting metabolic rate came down. So what they found at that Optifast is some of these people were gaining weight eating 800 or 900 calories. Okay, and then we just did a little exercise intervention, 2 or 3 times a week, and their body composition kept improving and the metabolic rate kept going up just a little bit. And it made the whole difference in the trajectory of the final outcome.
Yep. But when it's not an inpatient study, you can't say that people gain weight on 800 calories a day. You can't.
Okay,
you can't.
Okay.
Because,
no, I got it.
Because adherence is an issue.
No,
I followed up with a competing company, Ross Abbott, to develop an 800-calorie formula with enough protein and in it to preserve lean body mass and enough fat in it to prevent gallstones. Because the big problem with Optifast is it had so little fat, there was no cholecystokinin signal to tell the gallbladder to contract. It would just sit there and collect cholesterol, and bam, big stone.
Yeah.
So if you put 30 grams of fat into a formula, you prevent gallstones. We did that, but then I did a study where I used a lot of endurance, not resistance.
Right.
And this is where I learned the harm of excess endurance, because we had them doing 2 hours a day of cycle ergometry while they're eating 800 calories a day, and compared to the group that didn't exercise, their metabolic rate came down 15%.
Yeah. Oh.
And that's I didn't like that data. Nobody likes that data. But then it was corroborated by Claude Bouchard and Angelo Tremblay in Quebec. So
Right.
There are major limits to particularly for overweight people, to their tolerance of endurance or aerobic exercise. So I'll shut up because I don't like giving.
I just wanted to mention that
yeah,
fact.
I really appreciate that.
It was interesting. So.
But the resistance exercise is key as a component.
I believe that's true.
I think that's true. Thank you. David.
Steve, so a bit of a nerdy question, sorry. The studies you were referring to before that would find higher saturated fat in the blood for those people who were not on a ketogenic diet. I'm assuming one, you're speaking to free fatty acids and not including triglycerides found within lipoproteins, right?
That was actually in the triglyceride fraction.
Oh, it is the triglyceride
Yeah, we fractioned triglycerides, cholesterol esters, and which is fatty acids, esterified cholesterol, and phospholipids. FFA free fatty acids are really difficult to study because you get hydrolysis depending on how you draw and store the sample. So I've sort of backed away from FF. Anyway.
That's good. That leads me to my next nerdy question, which is so do we know how much of those were palmitic acid potentially originating from de novo lipogenesis? In other words, are the people where we see the higher saturated fat in the blood, a larger proportion of those might be actually due to de novo lipogenesis specifically?
Yes.
Okay.
But the problem with palmitic acid is there's a lot of it in foods. We use palmitoleic acid, which is a monounsaturated that is, unless you eat avocados and anyway, there are two foods that contain palmitoleic acid. But if you're not eating those two relatively unusual foods, then what you see in the blood is de novo lipogenesis. And when we feed people, increase their carbohydrate, in most people, palmitoleic acid goes up, indicating increasing de novo lipogenesis. So it's a better marker.
But that's why I was interested in the esterification, because as I understand, the initial process of de novo lipogenesis is first palmitic acid before it becomes palmitoleic acid. And during that palmitic acid portion, it can get esterified to some of the phospholipids and the cholesterol to become cholesterol esters.
The simple answer is yes.
Okay.
But in studies like the atherosclerosis risk and community studies, ARIC, the published data, palmitic acid and palmitoleic acid in phospholipid and in cholesterol esters, and in phospholipids, all three of them, when they go up, they're associated with increased risk of diabetes, heart disease, and mortality.
That makes perfect sense.
DNL is not a good thing to happen in people.
Right.
Yeah.
There's no good reason for us to be making fatty acids at a large quantity.
If your body's turning glucose into fat, you're eating too much carbohydrate.
Yes. Thank you.
Yeah.
Miriam here with just first I want to say, Virta Health, the posts on that are just amazing. Posts are amazing. I send all of my clients there to learn about the electrolytes and about thyroid function, because it's big in my world.
Thank you.
So, yesterday when I talked, I said something about the racemic beta-hydroxybutyrate not being a signaling molecule. But I talked to Dom this morning, and he said his preliminary research in cell research it looks like it is, and it lasts longer than the form of the BHB that we make, the D form. Are you guys looking at any of that in like all of the work and all of the data that you do? Are you looking at anything like that about racemic versus non-racemic? Or are you just doing it?
Yeah, so there are two forms, D and L. We make D. Most of the ketone ester, or not ketone esters, the ketone salts that are sold are the mix. Jeff Volek is doing quite a bit of research on this as well, and I'm not allowed to say much, except that its half-life is quite a bit longer, so it doesn't have this quick turnover. But it may be that there is no optimal isomer for acetoacetate. Our body, when we make acetoacetate, we make most of it, we then convert it into beta-hydroxybutyrate, but it can be converted back to acetoacetate, and then when it gets converted back to beta-hydroxybutyrate, it's in the D form, not the L. So you can actually switch the isomers by going back and forth between, switch from the less metabolically tolerated L form to the D form by going through acetoacetate.
Amazing.
A long answer, but
Yeah,
it's,
no,
it's,
thank
it's,
you very
you know, this is very complex. Yeah, anyway.
Great presentation, and thank you, Virta Health, for doing that fabulous work and getting it out into the scientific literature. It's so needed. My question has to do with the app and how you work with the clients in the app. I noticed there's a health coach and a physician. They're both Virta Health?
That's correct. The
And
physicians are a separate group because we in the Virta management cannot tell the physicians how to practice medicine.
Well, and
so they're a separate group.
That was kind of my question, do you then interact, or does the client interact with their physician, and does their physician interact with your physician, or is it just completely separate, and you say, well, their current physician's probably not following any of this, or they don't like it, and so it's very independent? Do you involve the client's personal physician in this as well?
Yes, we do. But right now, the world of virtual medicine practice, some of it's very archaic. The only way we can send patient-sensitive data, HIPAA-compliant data transmission, is through either a phone call, which is very difficult when you have two professionals working hard,
Right.
or by fax.
Oh, jeez. Yikes.
So anyway, we're working on that. So yes, we send monthly progress reports, but when we take on a patient with type 2 diabetes on meds and hypertension on meds, we let the primary care physician know that our physicians will be managing those, and we send them reports monthly on the patient progress.
Now I get it. Thank you so much.
Dr. Phinney, I'm a big fan of yours and Virta, so thank you for all you do. So a follow-up question to hers a little bit. So as a health coach, I'm curious to know how you work, or how your health coaches work with the patients, and what qualifications your health coaches have.
Probably the simple majority of our health coaches are registered dietitians, but many of them are not. And I'll be a little cynical here, and I'll say that when we hire somebody who's a registered dietitian, there's a lot we have to have them unlearn to do what we do, because it goes directly against what they've been taught and led to believe. But most of the dietitians who come to us are so fed up with the standard things they were taught, and they've already read the stuff we do. It's not hard to do that. But they all go through a training program, and they all go through a testing program. But we have people with behavioral medicine training, family therapists. We have some people who have from an exercise background. And then each patient gets their own personal coach who they deal with 5 days a week. And then there's a weekend coverage where there's weekend coaches who manage them. Our coaches are in pods of 3. So they have coverage if somebody is out, so on. So it's actually a very structured program. I'm not responsible for that, and because of that, it's going very well.
Thank you.
Eric Westman, Durham, North Carolina. Steve,
Have we met?
I'm a big fan. Pardon?
Have we met?
Have we met?
I think I saw your name in a book once.
Oh,
With me.
the New Atkins.
Yeah.
Well, so as a clinician and a clinical researcher, I'm struck by sometimes we see what we want to see as clinicians. You can talk to a doctor and we see them here and they're all excited and here's what they find and all this. But then when you line up 100 people in a row, it doesn't really all come out the way the doctor says it would. If I take 100 people in a consecutive sample, follow them for a year, I get a different result than if I just follow the people who lasted a year, because the people who dropped out didn't last a year. So anyway, you want to take a clinical doctor's word with a grain of salt unless they've really collected all of the information. So what I'm trying to get at is I see people who've had diabetes for 20 years come off insulin in a week. Now, I wonder, is it really true in the Virta data set, which now you have hundreds of people with diabetes, that the duration of diabetes really predict outcome? Or it could be even slower weight loss, slower progression. And if you haven't done that analysis, I'd like to see it, because in my clinical practice, I don't think duration really matters.
We got very prompt, but most of the insulin reduction we saw happened in the first month. And it was still going out to 3 months. After that, the tapering was very, very slow. But, Eric, we humans are remarkably diverse. So yeah, we've had people, we had a person with 300 units of insulin who was off in 5 days.
Yeah, but no,
But then we have people who were diagnosed, maybe they had diabetes longer, but they were on insulin diagnosed 3 years before, and we can't get them off. So they're very heterogeneous. So we have,
So you haven't done the regression analysis that just simply looks at duration of diabetes and outcome. That's all I'm asking for.
We have not done that.
Yeah, well, all right.
So I can't give you the results how that works for us. There is, in terms of standard lifestyle programs, not low-carb nutrition, and like the look-ahead study, the duration of diabetes was an important predictor of outcome.
Yeah, but they weren't using keto.
Exactly. We're working with a much better tool. They're beating on the tree with a stone axe, and we got a chainsaw.
100%. So now, I wonder for the future, we used a medical student program at Duke to deliver keto foods once a week. It was lightly expired meat that's actually still very nutritious, but you can't sell it. So it was donated locally sourced.
It's good if you had a lot of chili powder and onions too, right?
Well, no freezer burn yet with these meats, but so my world record now is taking someone off of 200 units of U300, so 600 unit equivalent insulin in 3 weeks, so she didn't want to start the program. She said, Doc, I'm not going to do that, it's too hard. But I called her on the phone and said, what if we delivered the food? And she said, well, okay, I'll give it a try. And she plummeted 30 pounds and, the great results.
Delivering food is a wonderful tool. Jeff Volek hasn't published, but he's completed a study in women with metastatic breast cancer, and they gave them all their food for 3 months, and they stayed in nutritional ketosis.
So is Virta Health?
Then 14 of those 20 people stayed in nutritional ketosis for 6 months. So it's a good way to start. But there was no free food for lunch, but I'm over time, so I don't want to channel Gary Taubes too much. But was there a question, Doctor?
Yeah. So is Virta Health going to go into food delivery?
No.
Oh, I think it should.
Talk to Sami Inkinen. But remember, he's a nuclear engineer.
Can I get his phone number? Can I get Sami's phone number? I'm joking. He's the anyway.
See me outside. Anyway. Thank you all for your patience and appreciate the opportunity.
Hey, hang on. Question. Sorry, Steve. Have you got some questions?
Who's the man behind the curtain?
Sorry, we got a few people on the live stream who might have a question or two.
Oh, okay.
Okay, we have a question from Lisa, who's asking about how you address obese patients. We've got one with strict keto for several years, lost 90 pounds. First 2 years, they've now plateaued for over a year at 300 pounds. Recommendation for this type of scenario, not an exerciser, unfortunately, but very compliant with ketones.
So if I heard it, 90 pounds of weight loss and plateaued after 2 years?
Yes, but now plateaued at 300 pounds.
Sure. we have a very, very powerful tool, but as Dr. Palmer pointed out, getting started early is more effective. And my simple answer to that is, don't let perfect be the enemy of good. And this person is compared to weight loss and maintenance of weight loss, compared into published studies and some of the data I showed here today, that's a superb outcome. That's in the top 99% of people who respond, effectively to this. So I've had people lose weight, keep it off for 2 or 3 years, and I don't know whether they're physiological or behavioral adaptations that occur, but then they can lose weight again. But to try to do it all in one fell swoop is sometimes so disruptive, either metabolically or behaviorally, because after people lose 60 pounds, people around them don't recognize them. And it's very disruptive. Your psychosocial microclimate, when you have major weight loss, is seriously disturbed. And one has to look at that as a longer-term goal. I'll just point out that in the bariatric surgery arena, the people who work with the bariatric surgeons to manage the patients post-op tell us that for patients with particularly gastric bypass surgery, where the surgery is greater, more than half of them get divorced within the first 2 years, because the weight loss is so disruptive to the interpersonal relationship with one spouse that it's very stressful. So bask in the glory of having lost 90, stick with it. It's not going to do you harm to follow it long term, and you may get to a point where you can lose more.
Okay, so
Thank you.
Let's go with one more. Okay.
One more from Scott. Protein-sparing modified fasting diets. Your thoughts on those versus doing those 2 days a week versus being in high levels of ketosis all the time?
I would recommend staying as much in ketosis consistently as one can. But if one then takes 2 or 3 days per week to cut out most of the fat and do the protein-sparing regimen on non-contiguous days, I have no problem with that, because the evidence says that they spare lean body mass and it does not have a negative effect on resting metabolic rate. The problem we saw with using continuous very low-calorie diets, whether it's 500 calories a day or 800 calories a day, is it drops resting metabolic rate by about 10%. And we never had the opportunity to study it, but my impression was that once people did that for 6 months with a 10% or more reduction in resting metabolism, when they refed, the resting metabolism didn't go back up, it stayed down. And in a more extreme situation with the Biggest Loser study, it was published that 6 years later, people who went through this radical program, abusive program of excess exercise and severe caloric restriction, they had a lasting 400 calorie per day deficit in their metabolic rate 6 years later. So don't do it too extreme, but doing it in modest amounts to kind of boost your rate of weight loss, I have no problem with.